Hello everyone, and welcome to the weekly Medical Mind the Bleep webinar series. Thank you so much for joining us. Today we're going to talk about medications in diabetes, which is a very important topic for all current F1s and F1s to be. We're going to be joined by Dr. Angelica, who's going to tell us all about it. Make sure you post any questions that you might have in the comments box on the Facebook event, and we'll make sure to answer them at the end. And feel free to post any questions to the Mind the Bleep email address, or just ask us on the website. We're happy to answer anytime. The session is going to be recorded, so if you'd like to have access to the content, please make sure you sign up for the future webinars. You fill in the feedback form, which we're going to post a QR code for at the end. And then you can access all the materials, and also you get a certificate for attendance, and we will get all the information that we need to make the future series better. So without further ado, I'm going to hand over to Dr. Angelica Sharma.
Hi everyone, thanks Sarah for the introduction. So I'm one of the F2s at the moment, have an interest in endocrine, did my BSc in endocrine. So today I'm going to be talking about medications in diabetes. So what we're going to cover is a bit of an overview of pathophysiology behind diabetes. We're mainly going to cover type 2 diabetes. We're going to have a look at the medications that we use currently and where they all fit into the pathophysiology, and then looking more into the risk and benefit profiles of these options, having a look at exactly how they work and where they work, and also a review of guidelines. I'm briefly then going to touch on insulin therapy and in the context of management of type 2 diabetes. As Sarah said, if you have any questions, drop them in the chat, and I've also got a couple of questions and cases, so please make sure you get involved. So starting off with the pathophysiology. Now, as you can see from this slide, many organs are at an interplay which cause increase in blood glucose and which are underlying the pathophysiology of diabetes. Now, in type 2, we know that there is impaired insulin secretion and potentially a loss of beta cell mass, but actually, predominantly, there's a resistance in the periphery of insulin, and that's why we have adipose tissue involved. We've got muscle, skeletal muscle involved, and they are all under insulin resistance, so they're not able to act with the insulin that's there. We've also got the involvement of the liver and the gut, and we'll see later how each of the medications fit into each of these organs. Now, before I go into the medication side of things, I think it's a little bit important to understand how we actually monitor the effects of these medications. So you've all probably heard of HbA1c. So this is our value that we use to see how well a patient's glycemic control is over the previous 3 months. Now, recently, or not that recently anymore, the units of HbA1c has changed. So previously we were using percentages, and now we're using these newer units. But typically at a threshold of about 6.5% or 48 millimoles per mole, that's our diagnosis of diabetes. But as we go on, we then use HbA1c for monitoring. So we set patients individualized targets, and we use these to think about when we might need to add medications, or to think about if the medications that we've added are actually working. In terms of individuals with type 2 diabetes, they don't really need to do much self-monitoring, so we don't expect them to check their blood glucose levels out in the community, though there are a few exceptions. So increasingly patients are needing to be on insulin to control their diabetes, and in this group we would expect them to do their own blood glucose monitoring. If patients are prone to have hypoglycemia, so this could be due to one of the medications we've started them on, or it just may be them physiologically, and we want to keep an eye on their blood glucose levels, in the community. And if they're someone who drives lots, so we've got HGV drivers, if their work and occupation is operating machinery, then that's the kind of people that we would be a bit more worried about and would want them to monitor at home. Now, we know that previous studies, so we've got the UK PDS and DCCT, they've shown us that actually better HbA1c control is really the cornerstone for reducing the micro and macrovascular complications of diabetes. And with every percent drop, there are massive implications for these end comorbidities and complications. So as you can see, across all the different sectors. So we've got amputation, so in terms of diabetic foot disease, microvascular disease, heart failure, and even MIs, so cardiovascular risk factors. And similar results were shown in the DCCT trial. And as you can see, with every increase of 1% of HbA1c, we've got great increases in these comorbidities. So it is really important to focus on. So I've got a question for everybody. So we've got Miss AC, 62-year-old. She's attending her annual diabetes appointment, and her latest HbA1c was 75, which is about 9% in terms of the conversion. So the question is, what average blood glucose level would she be sort of running at in the community over the past 3 months? So if we did give her some self-monitoring to do, what would it kind of be? Where would it be at? Anyone posting? Is there a bit of a delay, Sarah, maybe? Okay, so I'm just reading the chat, sorry, as I go along. So 10 to 14, 15 to 20, 10 to 15. So that's cool. I'll give you a formula, basically. So pause myself. Okay, so this is a bit of a formula, basically. So average plasma glucose over the last 3 months is 2 times the HbA1c in percentage minus 4.5. So a lot of random figures, but kind of useful. So you know that she's running at about 13.5 in the community. And as you can see from this diagram, you really need to have this tight control. And when we say about figures and sort of control, really, you want it to be somewhere between 7 to 9 if you're aiming for quite stringent control. And anything sort of in the 11s and the 12s, that's going to really increase your HbA1c. So just gives you a bit of an idea of what's actually happening when we're looking at these HbA1c readings. Now, we've come a long way in therapies. We're very lucky that we have so many options that we can use and so many options that target all the different underlying pathophysiology. It all started off back in the 1920s, thanks to Van Best and the dog, Nobel Prize winning for the discovery of insulin. We then moved on. We've got 2 in sort of the 1950s, sulfonylureas and metformin. And interestingly, they're still, you know, 2 of our top drugs that we choose right at the beginning. So metformin, still very much first line in the guidelines, and then on to sulfonylureas as well. We then went through the 60s, 70s, 80s. We've got more trials coming up then where loads of more population of patients were studied, and hence we could really pinpoint the need for strict targets. And now we're getting into sort of 2000s, 2010s, and that's where you get your cluster of medications that sort of all sound the same. And now, sort of coming into the 2020s, we're learning a bit more about them. We're going through sort of second generations of these drugs. We're learning a bit more about their risk profiles, and we're now able to specifically target these medications to patient groups. So we've come a long way since the 1920s. A bit about the goals of the treatment. So I think, and I've mentioned this, because we are so lucky and we have a variety of medications, we're really able to address the needs, the preferences, and the tolerances of all of our patients. So we're able to have a look at the risk, the side effects, the contraindications, and say, you know, this would be perfect for one individual, but actually this wouldn't be so great for the other. And I mean, it's a good thing, because more and more now patients are having increased life expectancy. We're seeing more comorbidities and complications of diabetes as they live longer. So to have drugs that can actually modify this, we're at a very lucky stage. Obviously, we want to optimize glycemic control as much as possible, and guidelines tell us some figures. So you would have heard HbA1c targets of sort of 7.5% is when you add in drugs, or the aim of kind of 7% of a good level. But actually, we're moving towards making these targets a bit more unique, because you wouldn't really, you may not want such strict targets in the elderly population, and patients may have their own wishes and concerns about their condition. Obviously, you want to reduce the endpoint complications, so the microvascular and the macrovascular complications, and increasingly now these drugs are helping us to do that, and the new trials are telling us more information on the underlying mechanisms. And you may think that actually the main problem is the high levels of sugar, but actually hypoglycemia comes with its own set of morbidities and mortality, exceedingly in the elderly population. It's sort of, you know, one of the causes. We all do our A to E, and a hypoglycemic event can cause falls. It can cause worsening confusion in the elderly. So that's something that we want to try and avoid as much as possible. So I've brought back that diagram, and as you can see now, where the medications I'm going to talk about kind of fit in, and you can come back to that. But just as an overview, you can see that they all, for one, have different targets, obviously leading to the same end goal of trying to lower blood glucose levels, but they also have positive side effects in a way. So SGLT2 inhibitors, although their main mechanism is to reduce the glucose reabsorption, they have side effects of improved cardiovascular outcomes and kidney, so renoprotective mechanism. And the other topic is weight. So this diagram is color coded. It tells us sort of the impact on weight. And this is a big thing for our patients. So some will have gone through a period of weight loss to try and get into terms with their diabetes and to improve their glycemic control. So if they've just had this period of weight loss, you may not want to start something that's then going to cause them to gain weight again. Or if someone is particularly obese and they would like to lose weight, then it would be sometimes counterproductive to start them on something that would cause them to gain weight. So these are the kinds of questions that we ask ourselves when we're starting the medications. And this is sort of a diagram, and you'll probably have seen this before, but it's the things we think about when we're starting medications. And I think it's really important because it really
Hi everyone, so sorry. I think we're having some technical difficulties, which we're going to sort out in just 1 second. Apologies for that. I think Angelica is having some issues with her internet, but she's going to be with us very shortly. In the meantime, if you can think of any questions that you might have, we'll be happy to answer them all later. So if there's anything so far that you'd like to ask about, then feel free to post in the chat. All right, welcome back. I think we'll be able to...
Sorry about that, guys. All right, everything back to where we were. Sorry about that. Right, okay. Right, so I'll just carry on from where I was, sorry, mild panic. So this is basically just an approach to the hyperglycemia. And moving on. So in terms of the guidelines are quite complex. There's a lot of guidelines from different organizations. So in the UK, we've got the NICE guidelines, but then we've got the American guidelines as well. So I've chosen sort of this flow chart to use. Essentially, the first line, if metformin is allowed, is metformin. And then we monitor, and then we can add in the various drugs. And then if metformin is sort of contraindicated, then we can start down a different pathway, which we'll go over. But for an overview, after we've gone through everything, this would be a good flow chart to use. Now, finding the best combination of therapeutic agents, it's often trial and error for the number of reasons I've listed. And if patients are started on something, we monitor them closely because we want to check for side effects, and we repeat the HbA1c levels because we want to see if it's actually having a good impact, or whether it's actually helping us to reduce this, or whether despite the therapy it's just staying at a high level. Now, novel agents, as I mentioned, allow us to not only target the glycemic control, but also the endpoint complications and the risk factors. So that's why in this diagram so ASCVD basically means cardiovascular disease, and CKD, in those individuals, we may want to go to those agents quicker than with patients that don't have those comorbidities. Now, this is another curve that you might see quite often. So it's the efficacy when using oral agents. And as you can see, if you just change from one drug to the other, you sort of get this plateau and the flattening. But then if you start adding drugs onto therapy, then you would hope that over time, that's what's really going to help bring down the HbA1c levels. And there's definitely patients who are on 3 medications and their control is still not where we want it to be. And I'm in GP right now, and you're kind of looking at the drug history and you're like, okay, I'll try to increase this one. But if they're all on the maximum, then really you're heading towards insulin therapy. So there are patients where it's very difficult to control their diabetes despite multiple management. Right, so kicking off then, the first one, the one we've probably heard the most about, comes up everywhere, is metformin. The class is biguanides, and it has a mechanism of action in 3 areas. So main action is in the liver, where it will decrease the hepatic gluconeogenesis, decreases glycogenolysis, and also fatty acid synthesis. In the intestine, there's been some promising studies which helps it to increase the incretin effect, and we'll talk about that a bit more, and also helping us with the intestinal microbiome and the bacteria that can potentiate effects on glucose homeostasis and metabolism. There's also some action on peripheral insulin resistance down in the skeletal muscles as well. Now, we know so much about metformin. As you saw on the timeline, it was one of our first agents really after insulin. So we know a lot about its risk profile and its side effect profile. With weight, it's weight neutral, so very good for patients who are kind of at the upper limit of their weight or sort of in the obese category. The way it works, it doesn't really cause any risk of hypoglycemia, so it's very nice for our elderly population. They don't have to worry about that side effects. And our studies, the UK PDS, the large scale studies, do show that it is good in reducing our endpoints. In terms of some lipid side effects, it does help to decrease some triglyceride levels, but actually it's probably not the best if you're trying to work on lipids. The commonest side effect really, and patients will come back with this, is the GI side effects. So kind of your diarrhea, your nausea, your cramping pain. And, you know, these can be really debilitating for patients. And that's why we try to titrate metformin. So we start them off on a low dose for a couple of weeks, so sort of 500 milligrams, and then you might increase that. The maximum dose is about 2 grams per day, so that's sort of your upper limit with this medication. And if it's still not controlled at that point, that's when you would consider dual therapy. Other sort of side effects, these may come up on exams, or you may see it in clinical practice, is vitamin B12 deficiency. The big one, sort of lactic acidosis, although the literature says it's more rare than we may expect it to be. And in keeping with the lactic acidosis, if a person is dehydrated or has had contrast, it may actually precipitate an AKI. In terms of contraindications, so have to monitor patients' renal function, and actually that's true for most of the medications. So when they're coming in for their sort of HbA1c levels at the annual checks, you want to make sure that you're doing the use and ease. So it's contraindicated in any sort of metabolic acidosis because of its impact on lactic acid. And there's caution in heart failure. So I've got a case. So Mr. Brown is a 62-year-old gentleman. He's got type 2 diabetes, doesn't really know what he's on, but he knows he's taking metformin. He's got a scan coming up, so CT abdo-pelvis with contrast, and his GFR's 40 when you tested it. So does anyone want to sort of write any advice they may give him in relation to his metformin therapy before his upcoming scan? Just post on the chat if you have any ideas or if you've come across this before. Okay, we'll move on. I'll tell you about it. So basically there's quite a bit about metformin and contrast, and kind of when to stop it, when to restart. So in this gentleman, we said his eGFR was about 40. So really you'd want to be stopping it about 2 days before his scan, and then thinking about restarting it kind of 2 days after the scan. In the meantime, you can encourage the patient to drink plenty. This is elective, so it's kind of in the community, but if they're in hospital, you may also consider IV fluids to prevent the contrast-induced nephropathy. So got another case that I'll give you a couple of minutes to read. And I think there might be a little bit of a lag. Sarah, I don't know if you're able to see the chat. You could just put a letter in, that'll be fine. Just pick a letter. So someone's gone for C to add gliclazide. Some more takers for C. Okay. Cool. So most people going for C. So I'll just go through them. The thing with this sort of scenario is this risk of osteoporosis. And we know that in patients who are taking SGLT2 inhibitors and Pioglitazine, it can actually increase the risk of osteoporosis. Now, the reason why it's not gliclazide is because it says she's quite a frail looking woman, and she lives alone, and because she's got this background osteoporosis, she's had a fracture recently. It's just that gliclazide may precipitate sort of hypos in this lady, and with her background and high fracture risk, if she did have a fall, that could be pretty fatal. And that's why in her scenario, potentially DPP4 inhibitor might be more safe. So that's why in this lady you may think E. So moving on to sort of DPP4 inhibitors, these are the class of drugs. They go by the ending of gliptins. So these are linagliptin and sitagliptin. And the way they work is when you have food in the GI tract, there's a release of what we call incretins, including GLP-1, and typically these are broken down by the enzyme DPP4. But actually having good levels of GLP-1 can increase the production of insulin, and it can decrease the production of glucagon. So therefore it is very helpful in reducing blood glucose. So the way that gliptins work is they try to inhibit the enzyme which would inactivate the GLP-1. And these are great because they're weight neutral. They don't have any risks of hypoglycemia. And generally, if you look at sort of their risk status and the list of sort of risks that come with them, they're pretty safe. So majority of patients should be fine with sort of gliptin therapy. And they have a good impact with lipids. They can decrease the triglyceride levels. And another good thing that patients like and helps with adherence to medication is that they're once-a-day dosage. Trials have shown, though, that they only reduce HbA1c very slightly, perhaps less so than the other medications that we have on offer. And studies have also shown that they don't actually reduce our major endpoints and cardiovascular endpoints as much as we might want. There's other anecdotal reports in the literature that they may increase the risk of pancreatitis. And so if a patient has had a previous episode of pancreatitis, it's kind of best to avoid these. And they can cause arthralgias, so aches and pains. If your patient comes in, you started them on a gliptin and they're saying, I've got joint pain, that's probably one of the side effects. But generally speaking, they are quite good and quite suitable for most people. But it is a shame that the reduction in HbA1c is not that great. Now, linagliptin is hepatically excreted, and therefore you don't really need to adjust it for renal function. But sitagliptin, it's renal excretion, so you do need to alter the dose. But again, quite easy to use, only once a day. Right. So then we've got a HGV driver who's come in. He was diagnosed last year. He's tried a bit of weight loss. He's also on metformin, which is working. So he's managed to come down on the HbA1c. And the question is sort of what would be the next suitable step? So I'll just wait. So yeah, just type a letter, have a guess. But again, just be thinking about in this sort of individual, what we would want in terms of their weight and things. Lots of people going for B, so making no changes. Any other ideas? Okay, most people saying not to do anything. One person saying adding glycoside. Okay, so it's between making no changes and adding glycoside. Now, it is really good that he's managed to reduce his HbA1c, so that's really positive, and obviously the weight loss and the metformin and the combination of that is working. But if we look at targets for these HbA1c, we would expect that it would be sort of 7.5. And if it is kind of over 7.5% or 58 millimoles per mole, you would still want to add in another medication, because although it's really good, we can sort of get a bit more tighter control. So then adding sort of exenatide that's kind of a third line, fourth line medication. So we could start with something a bit more simpler. Problem with glitazide, as the previous question, is sort of, again, hypoglycemia. We know that he's a HGV driver, so if we put in an agent causing hypoglycemia, he could be at risk and then would have to do some self-monitoring and things. Insulin, that wouldn't be so soon. That's kind of our end game, and that's when we've exhausted our other drugs. So in this case, something like pioglitazone, or at least out of this sort of SBA, pioglitazone might be the best option for him. So, gosh, these are another group of drugs. So Thiazolidinediones, or TZD. So these are the glitazone group, and one example is pioglitazone. And these work by the mechanism of PPAR gamma. This is sort of a receptor. It's found in adipose tissue, skeletal muscles, and it impacts and it helps us by reducing the peripheral insulin resistance, so in the adipose and skeletal muscles. And it's excreted by the liver, so it's quite good in patients with renal dysfunction. Now, it doesn't really cause any hypoglycemia. Again, it's once a day administration, and it does actually have a good impact on our lipid profile, so it can reduce triglycerides. And in trials, it's also shown to reduce the cardiovascular endpoints. But one issue with this group of drugs is weight gain, and this has got two modalities. So one is the lipid accumulation. It can deposit into the adipocytes, so that can increase weight gain, but also it can cause fluid retention. And this side effect is thought to be dose driven. So the higher the doses the patients are on, the more likely it's going to impact them. It can also kind of lead to things like bladder cancer, and that's kind of a novel link, but it is now coming into guidelines, and we've been sort of told that if you have a patient who's got bladder cancer currently, or has a background of bladder cancer, or even if they've got macroscopic hematuria. So if someone comes into GP with hematuria and they're on pioglitazones, that's when you would think that, you know, you need to sort of stop that medication and maybe switch it to something else. Now, as we mentioned in the previous question, it does have this link to osteoporosis. So it's been shown to be involved with bone resorption, and it can increase the risk of fractures. So again, always looking at the patient as a whole and all the comorbidities really helps when deciding which of these medications to use. And again, the contraindications then are sort of in heart failure, in bladder cancer, and also just macroscopic hematuria, which later may turn out not to be bladder cancer, but at that point you wouldn't know. So we start off on the low doses, and then we can up titrate. We always monitor for complications. So then if patients do come in with kind of fluid retention and things, we can grasp it early and switch the medications. So another case then. I'll just give you a couple of minutes. Just again, just pick a letter. So someone's gone for D, C. Okay, so I think for this one, the majority have gone for C. And yes, that is correct, because a side effect of sulfonylureas is weight gain. So unfortunately, due to the glycoside, this man's put on weight. So sulfonylurea is another class of drugs. They're also known as insulin secretagogues due to their impact. And so what they sort of do is they close the ATP channels on the beta cell membranes. And that's mediated through the SUR1 receptor. This causes depolarization in the cell, causing a calcium influx. And the main way that these work is by increasing the release of insulin. So now, because these have a direct impact on insulin secretion, these are high risk for hypoglycemic events, and you can see the mechanism there on the diagram. Now, these are one of the early drugs as well that were developed in 1950, so we do have a good profile for these too. They're quite rapid acting, and they also are involved in reducing our microvascular risk factors, so that's been proven in the previous trials. Now, in terms of risk, they can cause hypoglycemia, but also weight gain. And this is quite a worry for some patients who may not wish to gain weight. And actually, in a way, putting on that weight may then cause more risk, and it may not improve their glycemic control overall. And it's reported in the studies that actually over sort of 3 years, patients can put on up to 3 kilograms, but the effect of that will depend on sort of the person themselves and their weight at baseline. Now, because these work in terms of sort of stimulating the beta cell to produce the extra insulin, over time, they actually may become less effective, because over time, we do know that the beta cell loses its ability to secrete the extra insulin. So if it's then exhausted and, there's no more insulin, then you may find that someone's been quite steady on this therapy over a long period of time, but then suddenly their glycemic control is rising. It can also cause SIADH, so that's one of the side effects. And there's been some reports of cholestasis and potential involvement with deranged liver function tests. So if someone is on sulfonylureas, then just keep an eye on their LFTs. But these are quite more of the rarer side effects. The ones that you'll see firsthand are kind of the low blood sugars and the weight gain. Not too many contraindications. So there's potential that they may interact, and patients with sulfur allergies may react badly as well. And the other interesting thing is that they don't seem to have a dose-related relationship to the HbA1c. So increasing the dose of these drugs doesn't necessarily mean that the HbA1c is going to drop further. So you can just see how it works for the individual patient in terms of the side effects when you're titrating. Okay, so this is the next case. So this one's a picture. So it's a 65-year-old man. He's coming with acute onset scrotal pain and swelling. Extra points for kind of saying the diagnosis as well of what this shows. Yeah, so well done. So someone's got the diagnosis correct. So Cool. So yeah, most people got this one right. So yeah, well done. So the correct diagnosis is Fournier's gangrene. And this is sort of a new kind of side effect and complications that we're seeing with patients on dapagliflozin and SGLT2 inhibitors. So as you can see, it's sort of a necrotizing fasciitis, and there's gangrene there in the region of the external genitalia. Various bacteria involved with this, and essentially blood sugars that are elevated can impact on this. So in one study, 46% of patients that actually had Fournier's had elevated blood glucose levels, and this is not sort of the way you want to be told that you have diabetes. So this is kind of a catastrophic complication and could sometimes be a presenting feature of type 2. So sodium glucose cotransporter 2 inhibitors are the gliflozins. So we've got dapagliflozin, empagliflozin, and canagliflozin. And essentially, these are kind of the new kids on the block at the moment. So there's lots and lots of trials because they have found a benefit in heart failure. So using these drugs even in patients without diabetes has a major impact on reducing the endpoints from heart failure. Now, patients with type 2, they have a greater number of the SGLT2 transporters within the renal system, and especially in the proximal tubule. And so the glucose reabsorption is actually increased from the filtrate, which is not really what you want because you're trying to reduce the glucose level. So therefore, if we inhibit this transporter, then we can cause glycosuria, so glucose in the urine, which then would reduce the overall blood glucose. But their mechanism of action doesn't sort of end there. So obviously we know that they have this impact on the glucose side of things, but they also help with sodium excretion. And that's really useful with patients who may be at risk of fluid overload, and also patients that do have heart failure and sort of other intravascular issues. They're also renoprotective. So they can reduce albuminuria, and also they can actually maintain the eGFR in individuals with diabetes. So not only do they work with glucose homeostasis and reducing the glycemic control, they also have many other downstream effects which are useful in this population. So sort of the summary. In terms of benefits, they can help with weight loss. So as I mentioned previously, they prevent fluid retention and fluid overload. There's not really a risk of hypoglycemia. They do cause a reduction in the end cardiovascular endpoints. They're renoprotective. Their positive effects on the kidneys also reduces blood pressure in these individuals. And they're, again, once-a-day administration. But they do come with their own unique risk factors. So they do cause an increase in the risk of UTIs. They can cause an increase in risk of genital infection, so thrush. And as we mentioned, Fournier's gangrene. There's some studies that show that certain types, so one of them, canagliflozin, can actually increase the risk of amputations. But it's difficult to tell in these studies because we know that diabetic foot disease is one of the complications. So it's difficult to tell what impact SGLT2 actually have on that. And they have an increase in the risk of something called euglycemic DKA, which I'll ask you about in a second. So sort of contraindications is that if a patient has had DKA or you're suspecting DKA in A&E kind of setting, then you should discontinue the SGLT2s because they can precipitate it further. And if you have a patient who you perhaps started SGLT2 inhibitors on, but then they do go on to experience DKA, and then you later find out, they've been admitted for it, that's when you shouldn't be using them in that patient population. And they are renally excreted. They do have an impact on the renal function as well. So you're a bit limited on the patient population if you have patients with CKD. And these are, again, this is a summary of the absolute contraindication in terms of the eGFR is sort of below 25, but anything below 45 as per NICE guidelines is, you probably want to choose something else. So this is kind of what I was touching on earlier. So there's a conference going on at the moment, and basically empagliflozin, one of the drugs, has shown positive impacts on cardiovascular death and heart failure in patients with and without diabetes. So now there's kind of a move that you may see these drugs in patients without diabetes who have heart failure because they have shown a positive impact. And if you do see patients sort of with the maintained eGFR of kind of over 45, and they do have a background of heart failure, and specifically with a preserved ejection fraction with type 2, then this is one of the agents that's sort of new and shown quite promising effects. So in terms of this mechanism, so there's this mechanism that SGLT2 inhibitors can precipitate euglycemic DKA. So I've seen a couple of patients with this. In individuals with type 2, you don't really expect to see kind of a DKA picture. But does anyone know why these might precipitate to DKA? I think there's a lag, so I'll wait. But if anyone wants to suggest anything or something they may have read. Okay. Well, now we will all know. So these are a couple of diagrams which are quite useful when looking at the sort of mechanisms. So with SGLT2 inhibitors, as we said, they reduce the insulin secretion, increase the glucagon secretions, and essentially this can cause an increase in lipolysis and the free fatty acids, which can then precipitate ketogenesis. And this is more so when they're sort of, say someone's on SGLT2 inhibitors and they become unwell because of sort of the lack of the insulin, it drives further lipolysis and then generation of these ketone bodies. But actually the sugar levels themselves will probably won't be as elevated as you would expect. And when you do get into this sort of scenario, you also have an increase in your catecholamines and your cortisol, which then further exacerbates the lipolysis and ketone body generations. So this is one of the new side effects that sort of come about for these drugs. And usually we don't really measure ketones in patients with type 2 diabetes, and sort of scenarios where we've done it is maybe if patients sort of had a period of starvation, but actually they're moving towards saying, well, if people are being started on these SGLT2 inhibitors, then we need to have a low threshold in diagnosing this, and at that point perhaps testing for ketones might actually be very beneficial. So if you do see patients with sort of so if their sugar levels are normal and they're kind of got elevated ketones and picture of acidosis, have a look at the drug chart because it might be precipitated by one of the gliflozins. So all the drugs we've talked about so far have been oral, and then we move on to what we call injectables. And we touched on sort of the incretin effect previously, but another drug which is an injection is GLP-1. So the names kind of include exenatide, liraglutide, dulaglutide. And they work on a similar basis, but instead of actioning on the enzyme that breaks down the GLP-1s, we've sort of managed to create a analog. So to increase these levels to then further increase the insulin and reduce the glucagon. And just one interesting thing is that actually oral glucose has a greater ability to potentiate this effect because of the incretins, so instead of the IV glucose. And this is sort of a summary again. These are good because these cause weight loss. So if you come to sort of the end of the flow chart and you're kind of on triple medications, if you've got a patient with a BMI that's kind of over 35, so kind of obese, and even in patients where you think that perhaps at this point insulin is not the most suitable for them, perhaps because of compliance or their social situation, then GLP-1s are actually a promising step. They've shown in the trials to reduce cardiovascular disease. They've also managed to improve outcomes with patients who have non-alcoholic fatty disease. So now the liver disease is kind of gaining traction towards the non-alcoholic type, whereas previously most of it was down to alcohol. And these again have similar side effects to DPP-4, but a bit more of a focus on GI dysfunction and pancreatitis. The rarer side effects is there's been some reports that it could be linked with thyroid cancer. And the other thing with injectable therapies is the issues with local administration and the injection site reactions. So again, when you're starting someone on injectables, the education part and ensuring that they're actually able to manage it themselves is really important, and to be able to assess that. There's some contraindications, so sort of end-stage renal disease if the GFR is particularly low, and also one complications that patients with diabetes can get is gastroparesis, and because of the risk of GI dysfunction, it's sort of contraindicated in that group of patients. Other thing to say is that although they are injectables, it's sort of once weekly, so sometimes patients are reassured that it's not sort of every day. Cool. So then we get to kind of the end and thinking about insulin. So if we've gone through all these therapies and we still feel that the patient's not made good progress, that their glycemic control is still not where we would expect it to be, and they're not meeting the targets that we've set, we can look towards insulin therapy for individuals with type 2. But often, and sort of literature suggests this, is patients don't really want to get to this stage because they feel that they've failed in managing their condition. And so it may actually take some convincing to start patients on this. You have to then speak to them about the regime and make sure that it fits it amongst their day and their work life. You need to educate them about self-monitoring and the importance of this, because as we saw earlier, even if the blood sugar is a little bit out of range, it can actually really have big impact on the HbA1c levels and the glycemic control. Insulin's linked with weight gain as well, which might be a factor that we've avoided so far with the oral medications, but we get to this stage and it may be a side effect now. And injection pain. So depending on the regime, it could be multiple injections per day. And that's quite a big difference if someone was just taking oral tablets all this time. And NICE guidelines have sort of also highlighted this and kind of trying to tell us that we really do need to counsel the patients really well when we're making the change to insulin therapy. And not only do we manage sort of the hyperglycemia and monitor it, we also get the side effect of hypoglycemia. So ensuring that patients are well educated on what to do during a hypo, and also assessing whether they're aware when they're having a hypo as well. Now, there's various different insulin preparations, and the guidelines say that the ones for type 2 diabetes that we sort of start with are the intermediate insulin preparations. But you may then think that perhaps the control, when you review their diaries and things, is not great around meal times. So then what you can do is add in some short-acting insulin to take with the meals. Or you can tweak it so that they have their dose just with their largest meal of the day. And again, this is going to be a conversation to be had with the patient and how many times a day they're comfortable in administering insulin. So we kind of start with the intermediate acting ones if it's sort of a newly started someone on insulin. And if they want to reduce the number of times they're administering it, sometimes patients living in the community are not able to do it themselves. They have to have district nurses and things coming in, then you might go towards the long-acting insulin analogs as well. And I found this sort of flow chart because it's always difficult to start someone on insulin. You don't know exactly how much they'll need. You don't know if what you're going to start off with will actually keep the blood glucose levels under control. But a typical start is kind of somewhere around 10 units a day, or sort of 0.1 to 0.2 units per kilogram per day. And then you can kind of tweak this. So if they then develop hypos, you can reduce the dose, or if it's not really controlling the blood glucose well enough, you can increase by a certain amount of units. And there's no kind of right answer to this. You can't really predict how the patient will react to insulin therapy, and it will also depend on kind of how much residual beta cell function that they have left. But that's when you start tailoring management specifically for the patient. And then I touched on this earlier. So when you're titrating, you may think that actually before this meal, or after this meal, levels are particularly high, so then we can kind of tweak this time, or perhaps that you had it once a day and it's not quite controlling it, so you may want to sort of split the dose twice a day. So that's sort of a whistle-stop tour through medications and diabetes, going through some of the findings in the studies and the trials, and also some side effects and benefits. So that's what we have at the moment when we're in sort of clinical practice. And these are the kinds of, so the cases and the kinds of decisions you have to make based on the patient profile. So thanks very much. I'm sorry about my technical issues.
Thank you so much. I'm sure that everyone found it very useful. I definitely did. Thank you very much for your attention, and we would like to ask you to fill in the feedback form, which you can access by scanning the QR code. And if you fill in the feedback form, as I said before, you'll get a certificate for attendance, which is very good for your portfolio, and it's useful for us to make sure that the future sessions are improved. And in the meantime, if you have any questions, please put them in the comment section on the Facebook chat. And take, just spare a couple of minutes to fill in the feedback form. I'm just going to wait and see if there are any further questions. Otherwise, we'll just let you fill in the feedback form, and we'll see you next week for the next session. We'll give you, let's say, 5 more minutes, and if there are no questions, we're going to wrap it up.
Sorry, just say that if you want to look more closely at the diagrams, I know I've rushed through it, but it goes through all the mechanisms quite nicely. And I tried to choose ones that are the most understandable, because you can get really confused with all the underlying pathophysiology. Lots of people asking where you get the feedback. Hopefully you're seeing a QR code if I haven't messed it up. So you can access it via the QR code. But what I can do if you can't see it is post it on that chat as well. So I can try and do that.
Yeah, I think it'd be useful to post the feedback link.
Yeah, sorry, I'll try and do that now.
Sorry.
It's fine.
Okay, I've got it. 1 second.
Oh, I don't know what I've posted.
All right. I posted the link.
Okay, great. So thank you. The link should be on there too now. So.
All right, if there are no questions, please use the link to access the feedback form. It will still be available once we finish the live session. So thank you very much, and we're going to see everyone next week.
Thanks, everyone.